Let's tackle the warm-up review. First question, which adult structures are derived from the third, fourth, and sixth aortic arches? So the third aortic arch gives rise to the common carotid artery and the proximal part of the internal carotid artery. The left fourth arch gives rise to the aortic arch in the adult, and the right fourth arch gives rise to the proximal part of the right subclavian artery. And then the sixth arch gives rise to the proximal part of the pulmonary arteries and the ductus arteriosus. And remember that the fifth aortic arch doesn't give rise to any adult structures. Next, what agents stimulate the release of norepinephrine from the presynaptic bouton? So the three different agents are amphetamine, ephedrine, and tyramine. And the last question, what agents potentiate the action of norepinephrine by inhibiting its reuptake into the presynaptic cell from the synaptic cleft? So we had cocaine, tricyclic antidepressants, and we also mentioned SNRIs. Now let's get started with the lecture.
Hello everyone and welcome to another Step 1 video. Today we'll be talking about beats, which gives me a great opportunity to show you all my free-form rap style. With me always is DJ Funky Travis.
I'm not a DJ, I'm a videographer. Are you sure you want to do this?
Shut up, Travis. Today you are DJ Funky, and yes, I want to do this. I've got sick rhymes, and students will love them. Now, throw down a delicious beat, please.
Okay.
No. That's not funky enough. How am I supposed to get down to that? No. That's got no flow potential. Zero flow. Come on, Travis. What, are you just messing with me now? Do I need to take the funky out of your name, Travis? I will do it. Now, the next beat you drop better be so funkalicious that I want to eat it. Yeah, okay. Winky Bach. Makes me think of Chewbacca. Okay, Travis, I think you're just not ready for this yet. You need to work on your treble and your faders, all those types of things. All right, sorry students, not gonna work today. All right, so now we're gonna move on to the ECG tracing. So this is a 3-star topic. Some of you might have even 2 or 3 ECGs, and some of you may not have a lot of ECGs on Step 1, but you still need to know it. It is variable, so be willing and able to actually recognize all the different rhythms. So the first one we're going to cover is atrial fibrillation. So atrial fibrillation, or AFib, is the most common cardiac arrhythmia. Now atrial fibrillation is described as irregularly irregular. Let me say that again, irregularly irregular. So the RR intervals follow no kind of repetitive pattern. That ECG will show a great deal of randomness to those QRSs. Now the rate can be normal, but it is often increased. Now another important aspect of AFib is that there are no discrete P waves, and I'll explain in a minute why we don't see those P waves. So remember, when looking at it in an ECG that may be AFib, the two things you need to see is an irregularly irregular rhythm and no P waves. So what causes AFib? Well, we actually don't know exactly. We think that in AFib there is a triggering signal that arises from the pulmonary veins, but we have identified some risk factors. They include hypertension, and we see that in about 60 to 80% of patients with this, cardiovascular disease 25 to 30%, heart failure in about 30% as well. Now each of these is associated with left atrial dilation, which seems to increase the probability of abnormal electrical firing from the pulmonary veins. Now, when AFib is present, there's too much atrial electrical triggering. Then you don't get a real nice coordinated atrial contraction. I try to imagine the atria just kind of quivering with excitement, but it never gets out a real nice normal squeeze. And you can see this in some ECGs. The baseline isn't very smooth. It looks kind of jagged, but a very low amplitude. And because we don't get a coordinated contraction, we don't see the P wave. Now, as we said before, the rate can be normal or increased. Now, the atria are firing off a multitude of signals. Now, often this can result in tachycardia. Many of those signals get through to the ventricles, and then you get a rapid ventricular rate. Now, this is often the presenting symptom. So patients will complain of tachycardia, shortness of breath, a fluttering in their chest, or even angina. So what are some of the other consequences of AFib? Well, if the atria can't generate a coordinated contraction, then there can be pooling of blood in the atria. Now, what does stagnant blood like to do? It likes to clot. So that's why atrial fibrillation is so concerning, because the atria aren't contracting, that pooled blood forms clots, and then the clot can dislodge and then embolize to other sites. Now, it can travel to the right ventricle and then into the lungs, causing a pulmonary embolism, or if they have a patent foraminal valley, or if the clot forms in the left atrium, then it can dislodge and embolize in the brain and cause a stroke, or travel to other parts of the body and embolize there. So, how do we treat AFib? Well, first you need to know if this is a new or if it's a chronic form of AFib. If the atrial fibrillation is less than 48 hours old, you can do synchronized cardioversion. So you actually synchronize the cardioverting with the QRS segment so that you basically reset the normal rhythm of the heart. Again, you can do this only if it's new AFib. Why don't we want to cardivert an older AFib, something greater than 48 hours? Well, we just talked about those clots forming in the atria. What happens if the heart abruptly starts having big coordinated atrial contractions? You run the risk of dislodging the thrombus and then causing an embolus. So, if you have a clot in the atria, you do not want that coordinated atrial contraction. So in an AFib that's lasted longer than 48 hours or unknown duration, then the patient will need anticoagulation therapy. Now, what drugs do we use? Well, first we anticoagulate with heparin or enoxaparin, which is low molecular weight heparin. And then also at the same time, we also start Coumadin or warfarin. Now, once that warfarin becomes therapeutic over several days, we generally stop the heparin or the enoxaparin and just continue that warfarin until further treatment is decided. Now, what else do we do for chronic AFib? Well, there are two ways to treat chronic atrial fibrillation: rate control and rhythm control. So with rate control, all you're trying to do is, one, anticoagulate that patient to make sure that clot doesn't form or dislodge and go anywhere. And then two, make sure the patient doesn't go into a supraventricular tachycardia, so a real rapid rate. Now, what are your rate control drugs for AFib? It's digoxin, beta blockers, and calcium channel blockers, something like verapamil, but you use those in multiple combinations. Now, with rhythm control, you're actually trying to bring that atrial fibrillation back to normal sinus rhythm. Now, what drugs are used most often there? We use the antiarrhythmics. Sotalol, amiodarone are commonly used. Those are potassium channel blockers primarily. Flecainide, a sodium channel blocker, is also used. Now, why would you do rate control versus rhythm control? Well, both of these strategies have very similar rates of morbidity and mortality. Rate control has a simpler regimen, and patients who are over 65 and are asymptomatic tend to do pretty well in this regimen. Patients who are younger or who are symptomatic may benefit from a rhythm control method. AFib can be uncomfortable when it leads to that supraventricular tachycardia, so that's why you might want to convert them. Now let's move on to atrial flutter. So atrial flutter is very easy to identify on the ECG because it has the classic sawtooth pattern. So if you see an ECG with sawtooth pattern on there, that is going to be atrial flutter. So you actually do have distinct P waves. You just have a whole bunch of them. So AFib has no P waves and is irregularly irregular. A-fluttered has those P waves, and there's a bunch of them, and it's relatively regular. Now here you do have atrial contractions. However, because of the elevated rate, there may not be enough time for those ventricles to fill all the way. So in that respect, it can be very similar to AFib in some of the symptoms. But overall, A-flutter is not quite as severe as AFib, and also just how fast are these atria contracting, it's a good thing to know. The amount of atrial contractions taking place in AFib, usually over 300 beats per minute. Now that doesn't necessarily mean that it's getting all the way to the ventricles producing a heart rate, but the atria themselves are kind of quivering at 300 beats per minute. For A-flutter, it's a little less, maybe somewhere around 220, maybe up to 300. It's hard to know. Let's move on to AV blocks. So AV blocks, we're looking at in detail at the PR interval. And the first thing we're going to talk about is the first degree AV block. And the first degree AV block is just a prolonged PR interval. So a PR interval greater than 200 milliseconds. So this is bigger than 5 little boxes or one big bold box on your ECG paper. So this is a pretty benign condition overall and is often asymptomatic. Now the only reason why it might be a problem is that if you have that first degree heart block, you are more likely to go into a second degree heart block. So that's important there. Now there are a lot of people that are on things like beta blockers or calcium channel blockers like verapamil that end up giving that patient a first degree heart block as a side effect. Now if they need to be on that drug and that first degree heart block can be tolerated and careful monitoring should be implemented, but they can continue taking that medication without problems. So here's a relatively tricky question. What bacterial infection can actually cause a type of AV node block or heart block? Well, it's Borrelia burgdorferi, which can cause an AV nodal block. And the organism is what's going to be causing Lyme disease. So if you remember Lyme disease, that can cause these AV nodal blocks. Let's move on. We're going to talk about Mobitz type 1. So the second degree heart block comes in two different flavors, the Mobitz type 1 and the Mobitz type 2. The Mobitz type 1 heart block has progressive lengthening of the PR interval until a beat is blocked. So a P wave is not followed by a QRS complex. This is also is typically benign and asymptomatic. Now, Winky-Bach is another term for Mobitz type 1 heart block, and don't get confused. Mobitz type 1 is not a first degree heart block. Mobitz type 1 is a second degree heart block. Now, one way to remember this is that Winky-Bach will give you a warning before the beat is blocked. The other stupid way I like to remember this, and I kind of like this one, is the cheerleader cheer, longer, 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 drop. That's a case of Winky-Bach. So remember, it's getting longer and longer than you're blocking that beat. Moving on to Mobitz type 2. So Mobitz type 2 is more problematic. There is no warning. There is a blocked beat that has no precursor warning and no precursor lengthening of the PR interval. So it is abrupt. So everything looks normal at first. There are P waves followed by QRSs, and the PR interval is not fluctuating, and then you just lose a random QRS after a P wave. So there is no warning in a Mobitz type 2. Now, the reason why Mobitz type 2 is problematic is they can progress more likely to a third degree heart block. And often these patients will be treated with pacemakers. Speaking of, let's talk about that third degree. So what is a third degree heart block? So this is where the atria and the ventricles beat independently of each other. So both P waves and QRS complexes are present, but there is no correlation between the P waves and the QRSs. So the SA node is not communicating with the AV node very well. So the atria are beating on their own, the ventricles are beating on their own. So they're like two neighbors that aren't talking to each other. Now, just doing their own thing. Now, the atrial rate is going to be faster than the ventricular rate. And now this is usually treated with a pacemaker. Now remember that the other one that required a pacemaker was that Mobitz type 2. And again, don't forget Lyme disease. Lyme disease can result in a third degree heart block. Now often you'll see third degree heart blocks with narrow QRS complexes. Now this is because you are still depolarizing through the AV node. However, there can be a ventricular focus which would result in a wide QRS. So about 2/3 of these are going to be narrow complexes, about 1/3 of these are going to be wide QRS complexes. Let's move on to Wolff-Parkinson-White syndrome. So this is a ventricular pre-excitation syndrome where you have an accessory conduction pathway from the atria to the ventricle that bypasses the AV node. So remember that AV node is acting to delay the signal to the ventricles to give time for those ventricles to fill with blood. The AV node also acts to keep the heart rate normal. So if the atria are beating too fast, there's too many signals coming through, then that AV node can actually simply block some of those signals so the ventricles don't beat too quickly. But in WPW, we have a sneaky bypass between the atria and the ventricles that ignores that AV node. Now, the most famous one is called the bundle of Kent. Now, there are lots of different accessory pathways, but the bundle of Kent is one of the more common and well-known ones. Now, as a result, you have an early ventricular depolarization that kind of looks like a delta wave. So a portion of the ventricle is actually depolarizing before the signal gets to the other part of the ventricle through the AV node and the bundle of His, the Purkinje system. Now, as a result, ventricles begin to partially depolarize earlier, giving rise to that characteristic delta wave. Now, I would be able to recognize that delta wave and know that that's WPW. Now, the reason why it's important to identify WPW is because it may result in a re-entry current leading to a supraventricular tachycardia. Now, re-entry from the bundle of Kent through the AV node system creates a cyclical pattern that causes a very severe supraventricular tachycardia. Patients can be very symptomatic. So what do we give for supraventricular tachycardia? Well, usually we give something like adenosine, except in WPW this is different. We don't actually give adenosine in WPW. We actually give procainamide, which is a sodium channel blocker, or you can give amiodarone, which is a potassium channel blocker. And that's to tone down that tachycardia. Now, the definitive treatment is destruction of the abnormal electrical pathway with radiofrequency catheter ablation. Let's move on to paroxysmal supraventricular tachycardia. So this is pretty plain Jane. So this is a rapid heart rhythm that originates at or above the AV node. So the name is pretty descriptive. Now, in general, there are two mechanisms, and this is similar to what we just talked about with WPW. There can be re-entry or automaticity. Now, because this is originating at the top of the heart, most of the time you will see P waves. Now, the rate can get up to about 200 or more, so it's still relatively high and can lead to lots of symptoms. Also, because a signal is originating at the top of the heart, we see narrow QRS complexes. Very important to remember that. So narrow QRS complexes. So overall, the ECG looks pretty normal, except that that rate is elevated. All right, let's switch gears here. Next, we're going to talk about the ventricular arrhythmias. These are easier to understand, and they come in fewer varieties, but they are more serious. So first, we have the premature ventricular beats, sometimes referred to as PVCs as well. And those PVCs are standing for premature ventricular contraction. So you might see them as PVCs or PVBs, depending on who you're talking to. So premature ventricular contractions are early occurring widened QRS complexes that have a bizarre morphology, which is markedly different from that sinus QRS complex. Now, most often they are the result of microentry at the level of the Purkinje fibers, which generates a premature complex due to a single transmission around this circuit. So the signal is coming from below the level of the AV node. So the electrical signal is not going through the usual avenues, and that's why we see kind of a fat, crazy-looking QRS. Now, in general, there is no P wave identified before a premature QRS complex. And the QRS complex of a PVC is, again, widened. It's bizarre, often notched with a QRS duration greater than that 0.16 seconds. So that's greater than 4 boxes. Now, a normal QRS should be less than 3 boxes, if you remember that. Now, a couple of terms you should know. Ventricular bigeminy is present when a ventricular premature beat follows each sinus beat. Ventricular trigeminy is present when 2 sinus beats are followed in by 1 ventricular premature beat. Now, most of the time, we don't need to worry about PVCs, and treatment is directed really just at eliminating severe symptoms associated with palpitations. Really, no study has shown that eliminating PVCs with antiarrhythmic drug therapy reduces the risk of arrhythmic death in patients, even with structural heart diseases. Now let's move on to ventricular escape complexes or rhythms. So an escaped ventricular beat or rhythm occurs when there is a failure of the sinus and the AV node to generate an impulse. So the top of the heart is not doing its job to provide the bottom of the heart with enough signals to produce a normal ventricular rate. So the ventricles are just kind of sitting there waiting for a signal from the AV node, and after enough time the ventricles get tired of waiting around and they kind of decide to make a signal of their own to get their ventricles pumping. Now there is an absence of P wave activity, and that makes sense, and the QRS complex is widened, which is going to resemble a PVC. Now usually you'll see a decently long pause, and then that QRS is going to come up just like a PVC. Now, persistence of this activity leads to multiple successive ventricular complexes representing an escaped ventricular rhythm with a rate that is slower than the normal sinus rhythm. Now, in cases of complete or third-degree heart block in which there is a sinus node activity but failure of conduction to the AV node, then you may get something called a junctional escape rhythm, where the AV node is the new pacemaker. Now, the QRS segments in this case are going to be narrow in that situation because that AV node is still able to coordinate a very fast conduction through the ventricles. Let's move on to ventricular tachycardia. So ventricular tachycardia, or VTach, as sometimes referred to, is defined as 3 or more successive ventricular complexes. So the signals are coming from the ventricles, but instead of being real slow like what we just talked about a second ago, this rate is very, very fast. Now, non-sustained VTach is a series of repetitive ventricular beats which have a duration less than 30 seconds. Sustained VTach lasts for more than 30 seconds. That's the designation there. Now, the rate of VTach is generally greater than 100 beats per minute, but may vary widely. Now, the rhythm is usually regular, although there may be slight irregularity of the RR intervals. Now, the width of the QRS complex, again, generally big, greater than 0.16 seconds, which is widened. So how would this differ from supraventricular tachycardia? Remember that supraventricular, it's just in the name, is originating in the atria above the AV node. Therefore, those QRS complexes are usually normal, not widened. And supraventricular tachycardia can become serious, but generally patients are not just about to die. Sustained polymorphic VTach can lead to immediate hemodynamic collapse. Big, big deal. So emergency asynchronous defibrillation is required for treatment. Let's move on to torsades de pointe. So this is a very specific type of ventricular tachycardia that is characterized by shifting sinusoidal waveforms on the ECG. So this is a ventricular rhythm, so it has a very wide QRS. It is a tachycardia, so it's very fast. The amplitude is what's different here. So the amplitude of the QRS changes. So it's a very small amplitude and very large amplitude, very small, very large. So it looks like a ribbon that's been twisted. That's why it's called torsades de pointe. So it's a twisting of the points or twisting of a ribbon as it can create that sinusoidal waveform. So this can progress, unfortunately, to VFib, which is why it's so dangerous. So anything that prolongs the QT interval can predispose to torsades. So there are certain drugs that are actually known for prolonging the QT interval. So let's go ahead and look at the study guide here and write this down. These drugs should not be given to patients that already have a prolonged QT interval. And a few I want you to know here. Macrolides. So macrolides, an example that would be erythromycin. Anti-malarial, so chloroquine and mefloquine are some that you have to avoid there. Antipsychotics like haloperidol, risperidone. Drugs like methadone, those are used for opiate addiction, heroin addiction. The HIV protease inhibitors. And then a lot of the antiarrhythmics themselves, so class 1A antiarrhythmics and potassium channel blockers. So a lot of the antiarrhythmics can actually cause arrhythmias, but the 1A sodium channel blockers and the potassium channel blockers, those are the big ones you got to remember there that can lead to torsades. So how do we treat torsades? Well, you treat torsades with magnesium. Now, for someone who just has low magnesium, we'd give magnesium maybe over a few hours. But here, if they have torsades, you're actually going to push that dose of magnesium to correct this arrhythmia relatively quickly. And then finally, let's talk about ventricular fibrillation, VFib. So this is a completely erratic rhythm with no identifiable waves. So remember when we talked about AFib looking like kind of a quivering pair of atria, not doing much, not making good contractions? Well, imagine what would happen if you had a pair of quivering ventricles without normal contractions. Nothing is happening here. So like sustained VTAC, this will actually lead to hemodynamic collapse and death, requires emergency asynchronous defibrillation right away. So these patients are going to die unless you get an abrupt correction to their rhythm. So you start CPL with ACL protocol, and then hopefully, really, you have to have a defibrillator around to get this going in the right direction. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Let's go through that together. First question, what is the initial treatment for ventricular fibrillation? So remember, you're starting your CPL, but what's the important part? Defibrillation. So as laid out in that ACLS protocol, the protocol also calls for certain medications, but for step one, you really just, VFib is going to equal, you got to shock them, so defibrillation. Next, what are the major characteristics of atrial fibrillation? So remember, it's tachycardia, usually. Sometimes you can have AFib without tachycardia, but think of tachycardia, and then think of irregular rhythm, and then think of no P waves. Next, what is the hallmark of a third-degree heart block? So remember, in a third-degree heart block, there is no correlation between the P waves and the QRS. They are completely out of sync with one another, so the atria are not talking to the ventricles. Next, what drugs are known to prolong the QT interval, increasing the likelihood of torsades in those at risk? So think of macrolides, think of chloroquine, think of haloperidol and risperidone, the antipsychotics, think of protease inhibitors, think of the class 1A antiarrhythmics, something like quinidine is an example, and then the class 3 antiarrhythmics, something like sotalol and amiodarone are examples of those. Next, what are the two different types of second-degree AV block, and how do they differ? So remember, there's the Mobitz 1 and 2. So there's Mobitz type 1, which is Winky-Bach, and you can remember that Winky-Bach gives you a warning. So you have progressively prolonged PR intervals and then a blocked beat. And then there is Mobitz type 2, which has no warning. So you have a blocked beat without any change in that PR prolongation. Next, why is warfarin anticoagulation important in patients with chronic atrial fibrillation? So in atrial fibrillation, you don't have normal atrial contractions, so the blood can pool in the atria and cause thrombosis or clotting, and then pieces of that thrombus can embolize, so it can break free, travel through the circulation, and cause a stroke or other problems. So patients with atrial fibrillation are at increased risk of thromboembolic stroke, so we anticoagulate them with warfarin to reduce that stroke risk. All right, that brings us to the end of the video. I hope you learned something. I'll see you next time.
Yo, what's up? You're watching DIT TV, the best place for new music and the highest yield medical knowledge.
We've got more great hits coming your way, but first, we had a request for this new release by Todd Skure, coming out next month.
That's right, so here he is, Todd Skure with The Rhythm of My Heart, only on DIT TV.
Across the street, I see your face down in my chest, how to skipping away. Is this love that I feel? I'm so glad you asked. Thumping out a rhythm that's entirely too fast. Heartbeat is irregular, irregularly dizzy and lightheaded, really scary. But I may survive somewhere, some way. Need a calcium channel blocker that will slow me down today. Oh, the rhythm of my heart is beating out of sync. Fibrillation of the atria, I think. Oh, that I don't die, but the EKG don't lie, and the doctor says my heart is an AFib. Oh, the rhythm of my heart was beating way too fast, but till tires am it slow me down at last. AFib is not a joke, and I sure don't want a stroke, so I need some more for and check.